Learned audience and my teachers, very good evening. It is very difficult to present here today after the presentation of my two great and beloved teachers. But it's also a privilege for me to correct myself on eco-assessment of RV function. So let us have a forget of LV for the next couple of times, as the RV is the forgotten chamber, sometimes we say. My learning objectives today with this presentation is to recap the memories of our eco views, to assess RV, to measure the RV size, RV volume, RV function, and PA pressure. And in this 2D image, which one is RV, the larger one or the smaller one? Well, how we can identify the RV? First, we have to identify the atrioventricular valve. The mitral valve is more basally placed, and tricuspid valve is more apically placed, and the ventricle always go with the valves. If we can remember these two things, we easily can identify with our previous picture that the larger one is RV here. I have just rotated right to left in this 2D image actually. And as RV lies behind the sternum with irregular endocardial surface as a complex structure, multiple echo views are needed to integrate in assessing RV actually. And what are the views? The parasternal long axis view, in RV inflow view, short axis view, apical four chamber view, RV focused view, and subcostal view. These views are needed to assess integratedly. This is the parasternal long axis view, RV inflow view, and parasternal short axis view in the different labels, and apical four chamber view, RV focused view, and a subcostal view. Now, the chamber quantification of RV. It usually, we can qualitatively assess RV. Usually, the RV is less than 2/3 of LV. And if it is more than 2/3 of LV but still less than LV, we can say mildly enlarged RV qualitatively. If it becomes equal, then we can say moderately enlarged. And if the RV is more than the LV, definitely significantly enlarged RV. And we also quantify the chamber RV by the basal diameter, by the mid cavity diameter, and the RV longitudinal dimension at the end of the ventricular diastole. What is the end of the diastole? It is just before the peak of the R wave on ECG. And the practical picture, the left panel showing the qualitative assessment, and here we can see that the RV is more than the LV size, so definitely enlarged RV. And if we see the basal diameter, 64 millimeters, so it is the dilated RV. And RV OT we should measure it in parasternal long axis view and parasternal short axis view. In the parasternal long axis, we can measure the proximal RV OT, and in the parasternal short axis view, we can measure the proximal and distal RV OT as well. This is the parasternal short axis view, and you can see the RV OT measurement proximally and distally, which is normal. And regarding the RV volume and pressure overload, we have to look the parasternal short axis view. In the parasternal short axis view, interventricular septal flattening, if the interventricular septal flattening is in diastole, it is the volume overload, and if it persists both in systole and diastole, it is the pressure overload. And yes, RV free wall thickness we have to measure in the subcostal view at the chorda level at end diastole, and the less than 5 millimeter is normal, and if it is more than 5 millimeter RV free wall, it is RV hypertrophy. And in this picture in the left panel, you can see the normal RV free wall, and in the right panel, it is a right ventricular hypertrophy. And RV wall motion we can assess in the different views. It is the RV inflow view. We can assess the RV inferior and anterior wall, and the inferior wall is supplied by mainly by the posterior descending artery of the right coronary artery, and the anterior wall by the acute marginal branch of the right coronary artery. And apical fourth chamber view and subcostal view shows mainly the RV lateral wall. Now, regarding the RV function, The systolic function, diastolic function, and global function we can assess by the various methods. And TAPSE by means of tricuspid annular plane systolic excursion is a good tool to assess the RV systolic function, RV free wall TDI by means of RV S prime, and fractional area change. Also, these two measurements we can take for RV systolic function assessment. And regarding diastolic function, it is like LV in the tricuspid inflow study, and of course with the right atrial size. And the global performance we can assess by the myocardial performance index, which is called TI index also. And here is an example of TAPSE measurement. It is an M mode measurement and tricuspid valve annulus in apical 4-chamber view. And in the apical 4-chamber view, if you keep M mode along with the tricuspid valve lateral annulus, we may see the systolic excursion, and anything less than 16 millimeter is called RV systolic dysfunction. And it is the example of that picture of previously I have shown the dilated RV. Though the RV is dilated, here the TAPSE is 21 millimeter with good RV systolic function. And RV basal free wall TDI by means of RV S prime, it is the tissue Doppler imaging in the basal RV free wall, and sample volume is placed in the tricuspid valve annulus or basal free wall to read the highest velocity, and anything less than 10 centimeter per second is RV systolic dysfunction. And fractional area change, yes, it is very easy actually. It is the end diastolic RV area and end systolic RV area, and if you trace end diastolic RV area and end systolic RV area, the machine will give you the automatic result of RV fractional area change. And if it is more than 35%, it is normal, and anything less than 35% is RV systolic dysfunction. And here is a good practical example to assess the fractional area change in the diastole. In diastole, I have traced the end diastolic area, and in the systole, in systole, I have traced the end systolic area, and my machine has given me the automatic result 41%, that is normal RV systolic function. I will not go through in details about the RV diastolic function except right atrial size. And right atrial size measurement is very easier. We can measure minor axis, major long axis, and very much popularly we can do actually the planimetry of right atrial area. And but it should be measured in the ventricular end of ventricular systole, and it is normal 18 square centimeter. And I am going to the global function assessment by means of myocardial performance index. Often it is called RIMP. What is the basis of RIMP? It is the ratio between the isovolumic time and RV ejection time. And how I can gather isovolumic time? It is the summation of the isovolumic contraction time and isovolumic relaxation time. How we can elicit it? Yes. If the two echo views we can use, one is apical 4-chamber view, another one is the parasternal short axis view, or the RV outflow. In the apical 4-chamber view, in the RV inflow study, if we trace tricuspid valve closer to opening time, and if we detect RV ejection time from there, we will get isovolumic time. And if it is divided by the RV ejection time, which I can gather from RV OT pulse wave Doppler, then the machine will give me the result of the myocardial performance index automatically by the pulse Doppler method, which is normal less than 0.4. And another one is, this is a practical example of the calculation of the RIMP by the pulse wave Doppler method. And here you can see that tricuspid regurgitation is there. And in RV inflow, if there is tricuspid regurgitation, we should use the continuous wave Doppler. And we should trace the tricuspid closer to opening time, and at the short axis view in the RV outflow, we can trace the ejection time, and the machine will give me the normal automatic result of the RIMP. And this is the tissue Doppler imaging method to calculate the RIMP. We can calculate the RIMP in a single view here. In the apical fourth chamber view, if we put the tissue Doppler pulse wave in the basal RV or tricuspid valve annulus, we can trace here the tricuspid valve closer to opening time and the RV ejection time in a single view, and the machine will give the result automatically, but the cutoff value here is the 0.5. And this is the practical example from the tissue Doppler imaging method to calculate RIMP from the tricuspid valve closer to opening time and the RV ejection time. And here we can see the 1.4 is the RIMP, which is abnormal. And last of all, just estimation of the pulmonary artery pressure. We can estimate the pulmonary artery pressure by a very good tricuspid regurgitation jet velocity. So, in a view in which we can take a very good tricuspid regurgitation jet, we should calculate from there. And which is the basis? If there is no RVOT obstruction, so right ventricular systolic pressure is equal to pulmonary artery systolic pressure, and here right ventricular systolic pressure is the transtricuspid pressure gradient and right atrial pressure. If we can add from this gradient, we can get the right ventricular systolic pressure, and that is the pulmonary artery systolic pressure. And how can we add the right atrial pressure? Yes, from the subcostal view, if we see the IVC and the respiratory collapsibility of the IVC, we can take the right atrial pressure as 3 or 8 or 15 from this table to see the IVC diameter and the respiratory collapsibility of the IVC. And this is the very much practical example to calculate the pulmonary artery systolic pressure. The tricuspid regurgitation jet velocity is 4 millimeter per second, which is the pressure gradient 65 millimeter of mercury. IVC diameter is here 24 millimeter, and inspiratory collapsibility is less than 50%. So RA pressure is 15 is added here with the tricuspid gradient, and pulmonary systolic pressure is 80 millimeter of mercury. And can we calculate the pulmonary diastolic pressure and pulmonary mean pressure? Yes, from a pulmonary regurgitation jet we can calculate it. If we want to calculate the pulmonary diastolic pressure, we have to interrogate the end diastolic velocity of a pulmonary regurgitation jet. And if we want mean pulmonary artery pressure, we have to interrogate the early diastolic velocity of a pulmonary regurgitation jet. And if we add the RA pressure with this gradient, we will get the pulmonary diastolic pressure and the pulmonary artery mean pressure as well. And today I am pending these topics of 3D imaging or RP strain as because I want to take a privilege to meet you once again with this session in future on another occasion. Thank you very much for patience hearing.